Picture this. A patient walks into your clinic complaining of an absolutely brutal sore throat, right? It's one of the most common presentations you're ever going to see, but hidden within that seemingly simple complaint is a really critical triage decision. Welcome to this explainer. Today, we're going to break down the pathophysiology, the diagnosis, and the exact treatment protocols for tonsillitis and adenotonsillitis. We'll look closely at these two incredibly common presentations and map out the clinical pathway you need to confidently manage them. All right, here is our game plan for today. 1. Defining the anatomical targets. 2. Viral versus bacterial etiology. 3. Recognizing the clinical features. 4. Investigations and diagnostic criteria. And finally, 5. Medical and surgical treatments. So before we jump in, I want you to keep this central question in the back of your mind. How do you actually differentiate a completely benign viral sore throat from a bacterial infection, one that could potentially lead to devastating complications like rheumatic fever or even severe mechanical issues like airway obstruction? This is the high-stakes puzzle we have to solve to protect our patients from long-term harm. Okay, let's start with Section 1, defining the anatomical targets. It really all begins with geography. Tonsillitis is strictly defined as the inflammation of the palatine tonsils. You know, those oval-shaped pads of tissue sitting right at the back of the throat. But when we upgrade to talking about adenotonsillitis, we are dealing with the concurrent inflammation of both those palatine tonsils and the adenoids, which sit a bit higher up behind the nasal cavity. The absolute crucial distinction here is whether the inflammation is isolated or if those upper adenoid tissues are joining the party. Actually, as a quick anatomical refresher, the adenoids are part of Waldeyer's ring of lymphoid tissue, and when they swell up, they can literally obstruct the entire nasopharynx. And as you'll see, that anatomical difference completely shifts the patient's symptoms. Moving right along to Section 2, viral versus bacterial etiology. Let's look at the usual suspects. For both of these presentations, viral infections are actually the most common cause across the board. We're talking about heavy hitters here: adenovirus, Epstein-Barr virus, influenza, parainfluenza, enterovirus, and RSV. But your clinical radar really needs to peak when it comes to the bacterial side of things. The primary offender, the one you absolutely have to rule out, is Group A streptococcus, or GAS. Sure, there are other bacterial culprits floating around, like Group C and G strep, Staph aureus, H. flu, and even Neisseria gonorrhea. But GAS, that is your absolute priority. Which brings us to Section 3, recognizing the clinical features. Like we touched on earlier, the anatomy directly dictates the symptomatology. With isolated tonsillitis, you're going to see those classic infectious signs: severe sore throat, painful swallowing, which we call odinophagia, fever, exudates, maybe some halitosis, and tender cervical lymphadenopathy. But the moment adenotonsillitis kicks in, those upper inflamed tissues introduce a whole host of mechanical problems. It's like a sudden plumbing issue in the airway. On top of the standard sore throat, your patient is now going to present with nasal obstruction, rhinorrhea, constant mouth breathing, loud snoring, and that very distinct hyponasal speech. Now here's a massive clue for your diagnostic reasoning: age. As a classic high-yield exam fact, I want you to remember the numbers 5 to 15. Group A strep tonsillitis is most common in patients falling exactly into this 5 to 15-year-old age bracket. Basically, if your patient is in this window, your suspicion for gas should automatically shoot up. But flip the script for adenotonsillitis. We have a totally different crucial age bracket here, and that is 3 to 5 years old. Why? Well, adenotonsillitis is incredibly common in young kids, right as their adenoids hit their absolute peak maximum size, which happens exactly between ages 3 and 5. So they simply have way less real estate in the airway to accommodate any swelling. So why do we care so much about catching and treating this promptly? It all comes down to the complications. You really need to memorize this divergence. Tonsillitis carries severe systemic risks. We're talking paratonsillar abscesses and those terrifying immune-mediated conditions like acute rheumatic fever and post-streptococcal glomerular nephritis. Adenotonsillitis, on the other hand, that carries major anatomical and airway risks. That chronic obstruction can lead to obstructive sleep apnea, recurrent otitis media, recurrent sinusitis, and profound dangerous airway obstruction. It's two different disease pathways, leading to two totally different sets of complications. All right, Section 4, investigations and diagnostic criteria. We don't just guess when it comes to these infections, right? We follow a strict algorithm. Step 1, you clinically assess the patient using the Centaur or McIsaac scoring criteria. Simple enough. Step 2, Based on that score, you perform a rapid antigen detection test, or RADT, to quickly hunt for group A strep. And step 3, this is absolutely vital. If that rapid test comes back negative, but your clinical gut feeling for gas remains high, you must follow up with a formal throat culture. Sticking to these exact sequential steps is the gold standard of care to confirm or rule out a group A strep infection. Now, sometimes the standard algorithm just isn't quite enough, and you might need to dig a little deeper based on how the patient presents. For instance, if they have prolonged symptoms, posterior cervical lymphadenopathy, or maybe an enlarged spleen, you should definitely consider Epstein-Barr virus testing. If you need to actually see the exact degree of adenoid hypertrophy, a flexible nasal endoscopy is an awesome tool. And if you suspect the patient is suffering from obstructive sleep apnea because of all that enlarged tissue, polysomnography, a sleep study, is 100% indicated. Just a quick note, a lateral neck radiograph is really rarely required these days, so don't jump to that first. And that brings us to our final section, Section 5, Medical and Surgical Treatments. Let's lay out the bedrock of our medical management. If the infection is viral, listen closely. Do not prescribe antibiotics. Viral infections only require supportive care. That means hydration, analgesics to help with the pain, and nasal saline irrigation, which is especially helpful if the adenoids are involved. However, if you have a confirmed group A strep infection, that demands a strict 10-day regimen of penicillin V or amoxicillin to entirely wipe out the bacteria and prevent rheumatic fever. And if your patient happens to have a penicillin allergy, no problem, you just pivot to specific alternatives like ceflexin, clindamycin, or zithromycin. But what happens when the infections just keep coming back? We don't just yank tonsils out on a whim anymore. For recurrent disease, a tonsillectomy is recommended only if the patient meets the very exact American Academy of Otolaryngology head and neck surgery frequency criteria. You basically have to commit these to memory. It's 7 episodes in a single year, or 5 episodes per year for 2 consecutive years, or 3 episodes per year for 3 consecutive years. It's a highly structured threshold, 7 and 1, 5 and 2, 3 and 3. Now, what's really fascinating here is the shift in our surgical reasoning when the adenoids get involved. Yes, recurrent infections meeting those criteria we just talked about still warrant an adenotonsillectomy, but taking out both the adenoids and tonsils is also explicitly indicated for severe mechanical issues. This includes things like obstructive sleep apnea, significant airway obstruction, notable swallowing or speech impairments, or, and this is wild, craniofacial growth abnormalities that are directly related to chronic airway obstruction. The structural damage dictates the surgical need just as much as the infectious history does.
So, as we wrap up this explainer, I want to leave you with a final thought to mull over for your own clinical practice. Are we effectively balancing antibiotic stewardship while at the exact same time ensuring timely surgical intervention to prevent long-term craniofacial or systemic complications? It's a really delicate tightrope walk in medicine, right? Making sure we neither overprescribe antibiotics for a simple virus, nor delay necessary surgical relief for a chronically obstructed airway. Keep this framework in your back pocket next time you're looking into a patient's throat.